Okay, let's get started. Today we're going to be talking about hematopoiesis, and let's not waste any time. So, what is hematopoiesis? Hematopoiesis is taken from the word heme for blood, and poiesis meaning to make. And so hematopoiesis is the making of blood. And we have different subcategories for hematopoiesis based on which type of cell we're trying to make, which is something we're going to talk about a little bit later. But for example, you have erythropoiesis, meaning to make RBCs, or thrombopoiesis, meaning to make platelets. Now let's talk a little bit about where the blood is made in the body. Okay, and this is very, very important. Now, obviously, the baby can't start making blood at birth. They have to have blood made beforehand because they need to transport oxygen throughout their body. So, initially, in very early fetal life, they're going to be making blood cells inside the yolk sac, which you can see over here. Which you can see over here. And then later, the liver and spleen will start to take over, and they're going to be the ones making blood cells until the bone marrow finally forms, and then it will take over and it will keep going for the rest of the person's life. Okay, and you can see the exact timings here in the table, where you have inside a fetus, for the first 2 months, the yolk sac's going to be the one that's making the cells, and then from 2 to 7 months, it will be the liver and the spleen that's doing the work, and then from 5 months onwards, it's going to be the bone marrow. Now, in an infant, the bone marrow from all bones will have the ability to make red blood cells, but then later on through life, as you can see here in the graph, a lot of the bone marrow will taper off, and so it's only going to be specific bones that are going to make the red blood cells and to make the blood. Okay? So, let's talk a little bit about stem cells. I'm sure you've taken some of this before, but just to have a quick recap. Now you have totipotent cells, and these stem cells are very, very powerful. Why are they powerful? Because they can make any type of cell in the body, and they can even make cells that aren't specifically part of the human body, such as placental cells and extraembryonic cells. Okay. And then you have pluripotent cells, which are slightly weaker in that they can't make those placental cells. But other than that, they can make any cell inside the body. Right? They can make liver cells, they can make blood cells, they can make nervous tissue, they can make neurons, they can make fibrous cells, any type of cell that isn't part of the extraembryonic and the placental cells can be made by pluripotent cells. Okay, and finally you have multipotent, which each multipotent stem cell will have the ability to make a certain set of cells. So you can see here on the card, you'll have hematopoietic stem cells, which are going to specialize in making blood cells. Or you might have epithelial stem cells, which are going to make skin cells, and so on. Now, the key thing to understand about stem cells is that they have two key abilities. Okay? The first ability is mitosis, or to proliferate, which is when a single pluripotent cell divides and makes two of the exact same cell. Okay? And you can tell that both of them, that both cells have this ability. The other ability that both types of stem cells have would be to differentiate, which means that the cell is going to change from a stem cell to a different type of cell. Okay? So for example, you can see here in the embryo that you're going to have these embryonic stem cells which are pluripotent, so they can give rise to any cell in the body. Now these can differentiate into these somatic stem cells or into other cells, and then these somatic stem cells can also differentiate into specific specialized cells. Okay? And okay, so let's look specifically at the hematopoietic pathway, right? And this basically describes the whole lecture in a singular image. All right? you start with the hematopoietic stem cell, which is multipotent. All right, and then it will break up into your common myeloid progenitor and your common lymphoid progenitor. Your common lymphoid progenitor is going to be what makes your lymphocytes, so that's your B cell and your T cell. While your common myeloid progenitor will make all the other cells. So that could be platelets, it could be blood cells, or it could be the other immune cells. Okay? And during these steps, you're going to have these regulating factors that will essentially guide the hematopoietic stem cell as it's differentiating. And so they will tell it what to differentiate into. And this again redescribes what we've mentioned before, where you'll have the initial hematopoietic stem cell, and it can break off into one of two paths. Either it'll go into lymphopoiesis, where it makes a lymphoid progenitor and then a lymphocyte, or it can go into myelopoiesis, where it will go into a myeloid progenitor, and then it can follow into any one of these paths to make these different cells. So you could have granulopoiesis, where it'll make neutrophils, eosinophils, and basophils, monocytopoiesis, where it makes monocyte macrophages, erythropoiesis, where it makes red blood cells, or thrombopoiesis to make platelets. Now, let's look at a little bit about how you regulate hematopoiesis. And there are effectively 3 methods to doing so. The first one is apoptosis, where if you have too much cells, you can kill off a couple of them by apoptosis to keep everything nice and tidy and to keep everything regulated. The second 2 methods are your growth factors and the local environment. Now, in the local environment, you're going to have stromal cells. These stromal cells can be in the form of fibroblasts, they can be in the form of immune cells, and so on. And so what these will do is these cells will release proteins, which are growth factors, different growth factors from these ones, but they are still growth factors, and they will tell the hematopoietic stem cell what to differentiate into. The other thing that will regulate it is humoral regulation, and this comes in the form of hormones that will be made outside of the place of hematopoiesis. And so what do I mean by that? Well, here are a couple of the growth factors. Now you'll notice here that erythropoietin and thrombopoietin are made from the kidney and liver. What this means is that they aren't made inside the bone marrow. And that's what we're talking about when we mean humoral regulation. So, the first factor we have is GM-CSF, which will stimulate the hematopoietic stem cell and to make monocyte macrophages. And then you have GCSF, which stimulates granulocyte production, and that's your neutrophil, eosinophil, and basophil. Then we have erythropoietin, which, as the name suggests, it will stimulate erythropoiesis. And so this hormone will come from the kidneys, and then they will target the hematopoietic stem cell and drive it into making erythrocytes. And finally, we have thrombopoietin, which will stimulate the formation of megakaryocytes and platelets. And this comes from the liver. Now, these factors can be very, very useful. Why? Because let's say you have a patient that has chemotherapy, or a patient that you want to take their stem cells from. You can then give these factors to that patient, and that will stimulate their stem cells into proliferating. And because essentially you're giving the hematopoietic stem cell the instruction to start dividing and differentiating using these growth factors. And so what we can do is we can make these inside the lab, and we can give them to patients to stimulate their stem cell production. And here are a bunch of other growth factors. You have interleukin 1, 3, 4, 5, 6, 9, and 11, as well as TGF-beta and stem cell factor. Now, these don't really have much ability, but what these can do is they can synergize with other growth factors to create more proliferation. All right? Now, this is another very important slide, and it's important to focus on which factors will act on which cells. So like you can see, interleukin-1, it's not going to act on the stem cells, but what it will do is it will act on the stromal cells and tell them to produce growth factors. And the same thing applies to TNF-alpha. And as you can see here, we can see the thrombopoietin, erythropoietin, and GCSF and GM-CSF, which will act on the stem cells and tell them to proliferate and to differentiate. Okay, so it's very important to know which cytokines will act where and which growth factors will act where. So let's just have a quick recap of the stem cells. Because they are the key cells for making blood, but they are very rare and they basically look like lymphocytes when you're looking at them under the microscope. It's not enough just to use a microscope to look at them. So what we do is we stain them to check for CD34. Now the way we do this is we take an antibody and then we attach something that gives color. Okay, so we attach, for example, a dye to the antibody. So when we add the antibody to our histoslide, that's going to stain anything that has CD34 because the antibody will bind to CD34. And so anything that has CD34 on it is a hematopoietic stem cell. All right. And one other thing to point out is that you have erythropoietin that's made in kidneys, thrombopoietin that's made in liver cells, but other than that, all of the growth factors are made by stromal cells, which are the cells that are around the hematopoietic stem cells that stimulate their growth, that aren't stem cells themselves. Okay, let's look at how we look at the bone marrow. All right, now there are two studies that we typically apply to look at bone marrow. The first one is your bone marrow aspirate and your bone trophine biopsy. Okay, now where do we do this? What we do is we take a patient, we ask them to lie on their side, and then we insert our syringe into the iliac crest, as you can see here. And what we do is for an aspirate, we're going to withdraw some of the bone marrow material, and then we are going to spread it on the histology slide. And this will allow us to look at the cells and to check their size, shape, and their structure to make sure the cells that are in the bone marrow are behaving as they should and that they look the way they should. You also have a bone trophine biopsy where you punch the syringe into the bone and then you literally take out a piece of the bone marrow. This allows you to look at the structure and the cellularity of the bone marrow. So this is what an aspirate looks like under the microscope. And again, we are looking at the cells. We are trying to see if these cells are healthy cells. Okay, so you can see, for example, the red blood cells. You can see the white blood cells, such as the neutrophils, the monocytes, and the eosinophils and the basophils. And so it's telling you the shape and the size of the cells. But what this won't tell you is if you have a lot of cells in the bone marrow, too little cells in the bone marrow, and it won't tell you the structure of the bone marrow, which is where we look at the bone trophine biopsy. Now here you can see, because we're taking the cells directly, we're taking the whole chunk with the cells, you can tell how many cells there are by counting the cells that are in it. Okay? And you can also see how much fat is in the bone marrow. Now, usually, to calculate the cellularity, we take 100 minus the age of the patient. Okay, so what this tells you is that someone that's young, someone that's 20 years old, is going to have a very different cellularity to someone that's, say, 70 or 80. You'd expect a lot more cells in a younger person than in an older person. And so by doing this calculation, by doing 100 minus the age of the patient, it allows you to adjust your expected cellularity to the age of the patient. And so this is what it looks like when things aren't quite going right. You can see here on the left that the bone marrow is practically empty. All you can see here is just fat. There isn't many stem cells and there isn't much proliferation going on. Now you can compare that to the right, where there's where it's basically full of cells. It's packed with cells. Okay? And just one other thing to point out. This here in cellularity is measured in percentage. Okay, so usually, for example, for someone that's 20 years old, you'd expect the cellularity to be 100 minus 20, so that's 80% cellularity. Now compare that to here, where we basically don't even have 10% cellularity. Okay, or on the other side, where we have almost 100% cellularity on the slide. And so here you can see that there aren't many stem cells and there isn't much proliferation going on, and so it's hypocellular. While on the other side, there's a lot of stem cells, a lot of proliferation, and so it's hypercellular. Okay, now let's look at erythropoiesis, or the making of red blood cells. It has these different steps that the erythrocyte will have to go through. And it starts off, like we mentioned, with the hematopoietic stem cell. But then it's going to reach the proerythroblast. The proerythroblast is a cell that's very big. It has a big nucleus, and it doesn't have hemoglobin. Okay? And then it's going to start transitioning through these phases until it reaches a reticulocyte, which is a lot smaller, has a lot of hemoglobin, and it doesn't have a nucleus. Okay? Now, there are a lot of very fancy names here, but you don't have to worry about them, because we will talk about them a little bit more later. And we're going to give easier names, which is your early, intermediate, and late normoblast. But here in the table down here, you can see the comparison between a normoblast, a reticulocyte, and a red blood cell. So as you can see, a normoblast has a full nucleus with DNA, and of course, it's going to have RNA with it. Whereas in a reticulocyte, it's not going to have that nucleus or the DNA, but because it's not fully developed, it still has some of that RNA left over that it needs to get rid of. Okay? And finally, you have your mature red blood cell. It's not going to have a nucleus, of course, and it won't have any RNA left over because it got rid of it. And now finally, you can expect to find all of these cells, all of these different phases in the bone marrow. But you can only expect to find the red blood cell and the reticulocyte, although the reticulocyte will be at very low numbers in the blood. And so these are the stages of red blood cell evolution. You're going to have your proerythrocyte, or your pronormoblast, which, like we said, has a very big nucleus and has no hemoglobin. And also, because it has a lot of RNA, it's going to appear basophilic or blue. And now as you slowly progress, you can see here that the nucleus is getting smaller and that it's getting less and less basophilic, and it's getting more and more eosinophilic or red. Okay, and the reason it's getting less blue and more red is because it's losing stuff like ribosomes, stuff like RNA, and its DNA. It's getting more red because it's gaining more and more hemoglobin. Now, this reticulocyte image looks very, very odd, and that's because the staining was different for the reticulocyte image. For all of these, it's your usual hematoxin and eosin stain, but for the reticulocyte, we stained it using a supravital stain. This stain will target RNA, and it will light it up in this blue color. And so this allows you to identify that a reticulocyte has RNA inside of it, whereas a red blood cell wouldn't have RNA. These are the stages. Again, recapped. You're going to have your pronormoblast, and then your early, intermediate, and late normoblasts. Then you'll have your reticulocyte and your red blood cell. Now, the key thing to understand here is that once you reach your late normoblast, division's going to stop. Okay? So you're going to have your pronormoblast, it's going to divide, but then it stops at your late normoblast. Okay? And so one pronormoblast will give rise to 16 red blood cells. The other thing to understand is that inside the blood, you'll only ever see red blood cells and reticulocytes. If you can ever see normoblasts inside the blood, that means the patient has a clinical issue. Now let's talk a little bit about myelopoiesis. So you have your different stages of myelopoiesis again. You're going to have your myeloblast, and then it's going to progress gradually into your segmented neutrophil. Okay, so your myeloblast is going to have a very big and a very unsegmented nucleus. And as you can see, it's going to gradually get smaller, and then at your myelocyte level, it's going to start to invaginate, as you can see, or it will form a small dent. And this small dent is going to grow, the small invagination, it will grow until it becomes a segmented neutrophil. The other thing to understand is your granules. So you have primary, secondary, and tertiary granules. Your primary granules are going to appear in your promyelocyte, and then in your myelocyte, you're going to start seeing secondary granules, and finally in a band cell, that's when you're going to start seeing your tertiary granules. Now the final thing to understand is that for a segmented neutrophil, it's going to have this segmented nucleus. Okay, so the number of segments is very important for a neutrophil. Usually it should have 3 to 5 segments, but sometimes you can see less than 3 or more than 5. If you see less than 3, then what we're going to say is that this cell is a left shift neutrophil, or we can just call it an immature cell or a band cell. And finally, if it has more than 5, then this neutrophil is hypersegmented. Okay, it has more segments than it should. Now, this is again the different granules. And so the key thing that I want to highlight for you is the different stages of granules and the time each one appears. So you have your primary granule, which is going to appear at your promyelocyte stage, and then at your myelocyte stage you'll see secondary granules, and finally, once it becomes a band cell, that's when you're going to see tertiary granules. And the other key thing is that in your primary granule you're going to have this protein called myeloperoxidase. This protein, the myeloperoxidase, is very, very important because this protein not only allows it to attack the bacteria, but this protein is what allows a neutrophil to get through the body's tissues. And so anytime a neutrophil faces connective tissue, it can release myeloperoxidase, and that will allow it to cut through the connective tissue like a knife through hot butter. And again, this just shows you the different phases that we already described, but let's just look at the images and help describe them a little bit better. So first you have a myeloblast. A myeloblast is going to have a very large round nucleus, and it's not going to have any granules. And then you're going to have your promyelocyte, which is going to have your primary granules. Then you'll have the myelocyte. This is when you'll start to see your secondary granules, and it's also when you're going to start to see a little bit of invagination. This is going to continue, and you're going to get more invagination for the metamyelocyte, until you finally reach a band cell, which can have 1 or 2 segments in its nucleus. The other thing that a band cell will have is it's going to have your tertiary granules, and then you're going to get a neutrophil. Now, this is a very funny looking neutrophil because it's not a neutrophil at all. This is a neutrophil. You'll notice it has 3 segments, and it has the fully formed granules for a neutrophil. Now, we have the GCSF. This is the main player to encourage stem cells to become neutrophils. Now, because we've already talked about this before, I'm going to do this as a little bit of a pop quiz. And you can pause the video if you want to think about your answer. So first of all, where is GCSF produced? It's produced from the stromal cells, the cells that are around the hematopoietic stem cell. Second question, what does it stimulate? It stimulates the stem cell to proliferate, differentiate into a mature cell, and finally, it will promote the mature cell to function properly. And finally, how can this be applied clinically? Well, we can give patients a GCSF to increase the number of neutrophils that they have. Now, we'd want to do this in people taking chemotherapy or radiotherapy. In people with neutropenia, that's when they have very low neutrophils, so for example, people that have AIDS. And finally, if we want to harvest someone's stem cells, we're going to have to increase the number of neutrophils they have to give us more cells to work with. All right, so let's take a look at some other cells. Now, again, this is going to be in the form of a mini quiz. So what's this cell? That's an eosinophil. You'll notice it has very red granules, and so that's what makes it identifiable. Now the second one is, what's this cell? That's going to be a basophil. Now you'll notice that the key thing about the basophil is that it's very, very blue. All right, or it's very purple, if you want to be ultra fancy. And that's because it has basophilic granules. And finally, what's this one? That's going to be a monocyte. And the key thing about your monocyte is that what it's going to do is that once it leaves the blood and goes into the tissue, that's when it's going to be called a macrophage. Now, for the lymphopoiesis, it's a very, very straightforward process. First, you're going to have your lymphoblast, and then you're going to have your lymphocyte. Now, the key thing to understand about lymphocytes is that we can't tell, just from looking at the lymphocyte, if this is a B cell or a T cell. How do we want to identify? How do we identify it? We have to stain it using an antibody. Okay, we have to take an antibody that will bind to only B cells, and then we have to put it onto the slide, and that's going to show us which cells are lymphocytes. And finally, you have thrombopoiesis. Now, you're going to have your megakaryocyte, okay, which is a very, very big cell, as you can tell. And then what it's going to do is parts of the cytoplasm are going to break off the megakaryocyte, and they're going to float off into the blood, and these are going to be your platelets. You can see them here in these small circles. Okay, and if we want to form more platelets, the growth factor that's responsible for this is thrombopoietin. And that's all for today. Thank you so much for watching.